So as I said, this workshop is about implementing plans of safe care. And I just wanted to take a quick moment to say that this workshop is being funded by the Mother Cabrini Health Foundation, and we're incredibly grateful to them for this gift and the ability to be able to do these workshops for you today. A quick financial disclosure, the planners and presenters of this workshop do not have any financial relationships with any commercial interests, and no commercial support was received for the activity. And again, this workshop is being funded by the Mother Cabrini Health Foundation. And with that, I'm going to toss it over to Monica, who's going to teach you about the history of plans of safe care and how you can implement them. Thank you so much, Monica.
Thank you, Alex. Good afternoon, everyone. I'm glad you're joining us today. My name is Monica Taylor, and I'm the Director of Addiction Treatment Services here at Crouse Health in Syracuse. So next slide. To best understand the federal requirement for the development of plans of safe care, I'm going to provide a very brief legislative history about the Child Abuse Prevention and Treatment Act, CAPTA, that was first enacted in 1974. For states to receive CAPTA funds, they are required to ensure that they operate programs relating to child abuse and neglect. And over the past 48 years, some updates to CAPTA have been made that change and clarify some of the language and the stipulation and requirements for program improvements. Of significance for today's topic are changes that were enacted in 2003, known as Keeping Children and Families Safe Act, and in 2010, the CAPTA Reauthorization Act that specifically provided clarification on the definition of substance-exposed infants, and also at that point added fetal alcohol spectrum disorder. Next slide. Then in 2016, CAPTA was further amended by the Comprehensive Addiction and Recovery Act. Section 503 addresses the requirements for development of plans of safe care and clarifies the population requiring plans of safe care as born with and identified as being affected by substance abuse or withdrawal symptoms resulting from prenatal drug exposure or a fetal spectrum disorder. Next slide. So with these most recent changes also come federal and state requirements for data submission to the National Child Abuse and Neglect Data System, which is a voluntary data collection system that gathers information from all 50 states, the District of Columbia, and Puerto Rico about reports of child abuse and neglect. And the data collection required by CARA specifically includes the number of infants identified as being affected by substance abuse, withdrawal symptoms resulting from prenatal drug exposure or fetal alcohol spectrum disorder, the number of infants for whom a plan of safe care was developed, and the number of infants for whom referrals were made for appropriate services, including services for the affected family or caregiver. Next slide. So what is a plan of safe care? The plan is designed to ensure the safety and well-being of an infant with prenatal substance exposure, and it is promoting the safety of the infant while also developing a strategy to address the well-being of the family. It is typically developed with input from parents and caregivers in collaboration with the healthcare provider and other professionals such as addiction treatment providers. The plan of safe care considers different needs of the infant and caregivers, such as immediate safety, health, and developmental needs of the infant, as well as the health, mental health, and substance use treatment needs of the affected parents or caregivers, the kind of parenting and family support the family needs, as well as referrals to appropriate services and resources. Next slide. Back in 2016, the Office of Addiction Services and Support secured some in-depth technical assistance from Children and Family Futures focused on implementing plans of safe care in New York State. And at the time, Onondaga County and Warren County were pilot counties participating in the project. And in 2018, we convened here locally a group of local stakeholders representing addiction treatment providers, OB providers, local birthing hospitals, community health workers, children and family services, FQHCs, to begin the development of a process here in Onondaga County. And part of this early work was the development of this brochure. So this brochure is specific here to our county because it has some resources for our county, but it does provide a brief overview of what a plan of safe care is, helping a pregnant mom understand what this is. And so, this is something we're more than happy to share if this could be helpful in your areas, and you can adapt it how you see it fit. Next slide. The next 3 slides are going to be examples of plan of safe care templates here in New York State. And so the first one that you see here up on the screen, this one was developed by the Office of Family Services and Supports, and that was really the first available template. And the nice thing about this particular template is that it is available in multiple languages, as you can see here on this slide, and you can download this directly from the OCFS website. The one thing I can tell you in terms of when we started using this document with our patients early on, what they reacted to was the fact that right on top of this form, it says Office of Children and Family Services. So there was a fear that our patients said, does this mean I'm going to have Children's Division involved in my life? So we at the time had reached out to OCFS to see if we could maybe develop our own form, and you'll see that in a second, but I'll share with you first the DOH version of the Plan of Safe Care. Next slide. So the form that you see up now, that is the version that the Department of Health developed, and it is also available on their website, and you can download it right there. I think it's a little more strengths-based and might be more user-friendly. And then the last slide shows the version that we created. So what we basically did is we took what was on the OCFS form and incorporated in here, but the piece or the section that we added at the time were those educational topics. And that really came out of the work that our clinicians had done with pregnant women who were getting ready, for the birthing event. And there were just a number of topics that were really important during this time. And I think especially for our women who are on medications like methadone or Subutex, neonatal abstinence syndrome was a really important topic. And overall, I can tell you that our patients have responded quite well to this document, and they really see it as a roadmap throughout their pregnancy and beyond, and helping them identify, okay, here are some of the needs I have, and the kind of resources that are available to me in the community. So we had gotten some really positive feedback in completing these plans of safe care. Next slide. There are basically 3 New York State agencies that have all put out some guidance regarding plan of safe care. So the Office of Children and Family Services, they put out some guidance in the 2020 Child Protective Services Manual, where they basically note that positive toxicology of newborns does require a plan of safe care. They also sent out a memorandum in June of 2018, again addressing plans of safe care here in New York State. Next slide. And then the Department of Health in November of last year sent out guidance to all birthing hospitals and basically requiring reporting of aggregate data on substance-affected newborns. And this is done through the New York State CAPTA-CARA data to OCFS survey, which is housed in the Health Commerce system. So birthing hospitals in New York State had to submit first quarter data by April 15th of this year. So this is still very new. And what they basically, what the Department of Health identified as substance-affected newborns is basically that they display symptoms of substance withdrawal and have a positive toxicology screen. And in their guides, they also say, or they receive a diagnosis of neonatal abstinence syndrome or neonatal opiate withdrawal syndrome, or they receive a diagnosis of fetal spectrum disorder. So that is the guidance that DOH sent. And then the last guidance, this is from the Office of Addiction Services and Supports. So for those of you that work in OASIS certified programs here in New York State, there was a local service bulletin published in August of 2019. And this basically requires OASIS certified providers who are working with women who are pregnant or become pregnant while in treatment to ensure that a plan of safe care is developed prior to the birthing event. And I think, as substance abuse treatment providers, we have a wonderful opportunity to do this with our patients, because most of our patients are in treatment with us over a longer period of time, especially if they're on a medication like methadone or Subutex. They are have been with us for a while, and we have developed some really good therapeutic relationships. So for the primary counselor to then develop that, I think it's a very fitting process. Next slide. So what you can see here is that this is really a cross-system collaborative approach. There are multiple opportunities for different service providers that a pregnant woman is involved with to initiate this document. And I'm sure I missed some providers on this slide, but any of these individuals could initiate that plan of safe care. And ideally, we would want to see some kind of collaboration between different providers that a woman works with. Next slide. As I already said, ideally, we'd like to see it develop prior to birth, because it does become really this roadmap that provides guidance through the pregnancy. It is a comprehensive multidisciplinary assessment. And, as I said, there are multiple intervention points during the pregnancy, but even at birth or beyond, the plan of safe care can still be a good tool. And it does address both the needs of the infant and the family caregiver. And again, what's nice is it does provide that structure to ensure coordination of care. Next slide. The next two slides are basically some flow charts that the Department of Health has shared on their websites. It talks again a little bit about plans of safe care when they're developed prenatally or after birth, and it just provides some guidance again as to who should have a plan of safe care. And then in that green box in the top left area, it shows like all the different people who could potentially be developing that plan of safe care. And the one piece that's important, especially when the plan of safe care is developed prenatally, so if you are, whether you're an addiction treatment provider or maybe you're an OB provider, whenever you communicate information about addiction, you want to be sure you have the proper consent form signed by your patient. So in that way, you can communicate or share this plan of safe care, let's say with the birthing hospital. So when we complete the plan of safe care here in our treatment facility, the primary counselor at that point will ask the patient, what their birthing hospital is going to be and who their OB provider is, and they will obtain releases for those providers. So if the mom forgets to bring the plan of safe care with her to the hospital, then there's still the opportunity that we could share this with the hospital social workers so they have this for their record as well. Next slide. And then this is basically, again, another flow chart that the Department of Health developed, but this is more after the baby has already been born. And again, it provides some guidance as to, who should complete it. And this also provides guidance to the birthing hospitals in terms of which infants have to be reported into that HERTS system that I mentioned earlier, the survey that needs to be completed. Next slide. And then this last flow chart is something that was shared early on by OCFS. The reason I included that in here is because I want to also make a point about, when do you actually have to make a report to CPS, because I think there's a lot of confusion about it. So prior to the plan of safe care, any woman who gave birth to an substance affected infant was typically called into CPS. So you would call the hotline and make a report. But with the plans of safe care, if you have a woman who is adequately maintained, let's say on methadone, she's complying with her treatment and she's really working her recovery, and there are no child protective concerns for this infant due to the maternal substance use, then you no longer, or the birthing hospital no longer needs to make that call to Children's Division. So I think that's a really important piece, because historically, I think what happened is a lot of women who are on a medication for their addiction were even further stigmatized because now the baby, exhibited neonatal abstinence syndrome, for instance, and now they are being reported to CPS, and that's obviously very stressful to have that in your life. And now hospitals don't need to do that as long as there are no child protective concerns of this infant. Next slide. I already mentioned in an earlier slide the importance of getting a consent form signed, and because I don't know exactly what our audience is made up of, I wanted to be sure to at least point out that for individuals who have a substance use disorder, the records, addiction treatment records, are protected even more so than HIPAA. So there is something called 42 CFR Part 2. And so you want to be sure to obtain an appropriate release that meets the 42 CFR Part 2 requirements. And the Office of Addiction Services and Supports actually has a form on their website that you can download right there if you want to be sure that your consent form complies. And the important piece is 42 CFR Part 2 has a prohibition of redisclosure. What that means is if you get information sent to you and there was a release in place, you then can't go and send that release or share that information with somebody else. So that's just an important piece that, not everybody who's, not working in our field fully understands. So I wanted to be sure that I at least touch base on that. And then this is my last slide. I just wanted to let you know of some of the efforts here locally. As I mentioned, it was one of my earlier slides that here in Onondaga County, we did participate in a pilot in 2018. And then there are also now some current efforts going on where through the State Opiate Response Grant that our region receives, there is a group of regional providers that have all agreed to make sure that the plan of safe care becomes kind of a treatment standard, where these organizations that are part of this grant have all committed to making sure that they complete a plan of safe care with any pregnant patient in their system. And the Omnis IPA is kind of an offshoot of that. A lot of the organizations that are part of the SOAR grant are also part of the Omnis IPA, and this IPA has basically brought it to their board, and the board approved it to make it a network standard for all the organizations that are part of the Omnis IPA. So this is exciting work that's been happening here locally in Onondaga County. And with that, I'm going to turn it over to my colleague, Lisa Artner, who will be introducing a plan of safe care video demonstration. Thank you.
Thank you, Monica. Thankful to be a part of this initiative to raise awareness and competency surrounding the plan of safe care, such an important topic. And I'm an addiction therapist at Crouse Addiction Treatment Services. And I can say honestly, with agreement to what Monica said, that the plan of safe care really has been a roadmap. It is my GPS, my go-to in working with pregnant women. Really helps to ensure that the mom and the baby have all the resources they need. And in a moment, we'll watch a video demonstration of the plan of safe care with a patient, Danielle, that I have worked with in the past. And you'll notice that I am a member of the Motivational Interviewing Network trainer. So I have to give a little plug for motivational interviewing that there's a lot of partnership and compassion, affirmations, reflections, evoking from Danielle. That trust and safety is such a big key in working with patients, especially those with a trauma history. When they feel safe, they're more likely to tell you what's really going on so that you're able to really have all the information that you need in order to best help them and collaborate on this plan. And I know at times, as Monica had mentioned, that there is some ambivalence or hesitancy, especially around the area of child and family services. It could cause people to have their defense mechanism raised and really maybe even be a trigger to some folks. And so, the relationship and the words that we speak really matter, and how we're approaching that individual could be all the difference. I think that when we're partnering with them, when we're coming with compassion, and boy, they can tell in an instant if it's genuine or not. we are much more likely to have that professional relationship to be able to convey to them that the plan of safe care is good for them. It's good for their infant. And it's a wonderful way to connect with all of the providers involved in care for the mom. And so I think the biggest thing that I take from this also is taking the time to spend in educating the patient on different aspects, such as the neonatal abstinence syndrome, and how important that is for these new moms, so that mom and baby really gets all that they need. And by focusing on their strengths rather than their deficits, they're much more likely to collaborate with us on this plan. So let's watch this brief demonstration of Danielle and I collaborating on a plan of safe care.
So the plan of safe care that we've already met a couple times, we've been kind of coming up with this plan. It's that written list of resources that can help support you now while you're pregnant, and then also after you give birth to the baby. It's kind of a written plan that we have everybody who's involved in your healthcare here in outpatient treatment, the hospital, the OB office, everybody is communicating with one another. So it works together like a safety net. That way we're helping to support you for anything that you might need. It's kind of like a provider support network. So we're not all referring you to the same place. We just have one place that we're referring you by one person. So we just kind of work together to make sure that you and the baby have everything that you need.
So I've also, me and you have been talking about the fact that since I am having a baby on methadone, you know, CPS will have a conversation with me. Is that one of those copies go to her as well? Or him, the CPS worker that's going to be there?
So that's part of this process that is really important, Danielle, is that because you are on methadone and in treatment, sometimes it's not necessary for Child Protective Services to be called. Sometimes it is, but you know, certainly they can be made aware of anything that we're doing as well with your permission. That's a good question. I'm glad you're asking questions, because this is your plan, and it's not my plan, it's your plan. So
yeah, I actually wrote a list down so I wouldn't forget of things that I wanted to make sure that we went over since this is the last one.
Oh, good. So let's just go through and review where we're at. So we've got you and Dad listed as the household members.
Yes.
And then some of the things that you had mentioned as your goals that you want to work on after the baby's born was breastfeeding and continuing with outpatient.
You're also, I'm sorry, I didn't mean to interrupt you. Since I'm doing the breastfeeding, one of the things this plan helps me with is getting the pump right. Now that we're at the end of it, we can go see about getting a pump now, correct?
Yes. In fact, I contacted a few places to find out who might have a pump. And then once you sign a consent to be able to release your information, then we can kind of coordinate with them to get you connected so that you can have the breast pump.
Oh, thank you so much.
Yep, you're welcome. So continuing with outpatient, and then you and I are going to continue the Circle of Security Parenting. We'll finish that up, the parenting class we've been doing. And then you had mentioned the nicotine patches that you wanted to continue to wean off while you're at the hospital. And keep continuing working with Kathleen at the Upstate Perinatal Center. And then also the baby's pediatrician, we already got that set up. So we got a lot of things in place already for strength.
I love how, like, a lot of my stuff, you helped me make sure it was like easy on me. Kraus is like dealing with majority of me, like, since there's so many different doctors and I have different counseling and therapists and all that, like you made it really easy for me because they're all like based out of Kraus or, you know, right by the area that you're in. So that way it's easy for me for transportation and everything.
That's good to hear, because the last thing you need is a whole bunch of stressors right now at the end of your pregnancy or at the beginning after the baby's born. So I'm glad that it was more stress off your back, because that's the last thing that you need. So some other supports, you know, having a good, stable place to live. Baby's dad is a business owner, so he's employed. You have your dad and your stepmom, they're super supportive. And then working with our peer services specialist. You had also said you wanted to continue with the MRT and finishing that group, and working with us in outpatient, but then you also have a really great connection to the local recovery community. And so your support network there, I listed as well.
Okay.
And then some safety and protective factors. So one of the things I listed here was that you are learning some new skills in the parenting class based on attachment theory and child development. And so you'll be able to apply those things. Demonstrating emotional intelligence, being able to identify like the needs of the baby as well as what's going on inside of you emotionally. And you have a great awareness about community resources, because some of the resources on this list you brought to me, you knew about.
Well, actually, that's something I wanted to let you know that's on my little list right here. The resource that you gave me for the car seat, actually, I was really blessed because I called that resource and they referred me to have a doula come to the hospital with me when I had the baby. So, you know, you gave me some really great resources during this.
That is terrific. So you thought you were going for a car seat and you ended up with a car seat and a doula.
Yes, double.
Double. That's super.
Birthright, I know that me and you have discussed, talking to them. They gave me a whole package of stuff, like with diapers and clothes and everything.
Mhm. And I believe that we have a pump lined up for you. So I think that we'll be good with that. I just need you to sign a consent and then we can coordinate the referral for that as well. So here, Danielle, we just listed all the, like you said, all the people that you're working with. So we have, the folks that you're working with in maintenance therapy with Tasha and myself, an outpatient, also with Dr. Berry for your psychologist, and then peer services. And then we also did the Mommy and Me program at Krause.
Yes, I'm so thankful actually that you're doing this program with me because with the baby being born on methadone, there is, risks for things. And I think that program is amazing that, you can stay at the hospital, with the baby, even after my discharge, if the baby has to stay longer. That's like amazing.
Yeah, I'm so glad that you wanted to take part in that. So here's where your input comes in. So the Circle of Security Parenting I've listed, and then you had some other things that you mentioned that you were really interested in talking about, that you felt you had some needs that you wanted covered.
So the parenting groups, I was wondering, we discussed if I could be put into one with other women in it.
Yeah, so you, for the parenting, currently, you were the only one doing the parenting class, but I know you were interested in hopefully being part of a group. And so hopefully we'll be able to get a group going so that you can participate with other parents that are learning about the same skills as you.
Okay.
That would be great. So I know
And also-
Birthright is giving you a layette set and also diapers. And I believe that they also were the ones that said that they had the breast pump for you.
They're the ones.
And then the Lullaby League, that was where you were able to get the car seat. And then you said you actually ended up getting the doula services.
Yes, and right now with all the stress of COVID being out and not being able to know right now what exactly my plan is going to be, because we don't know for sure if I can have, a person come in yet with me in the birthing room. So that's a little nerve wracking, but it's good to know that I do have an doula I've been speaking with who is allowed to be there. So
Wonderful.
that's definitely a stressor that was taken off.
Well, it's so relieving to know that you won't be alone, that there's going to be support people right there at the hospital. Also, the social worker that's at the hospital will have a copy of this plan, and she'll be able to help you as well once you're there. So they can communicate with us so that when you come back to us, if there's some things we need to help you with, we can kind of pick up where they left off. So it's a nice communication system. Yeah, I'm so glad that you are able to ask for help and not afraid to say I have a need, and look at all these needs that you've had met. It's just wonderful to see this all coming together.
I never really, tried to reach out and get help. And, I always hear that it's out there. So it feels really good that I actually reached out because I've been helped so much during this whole pregnancy.
Well, you've been open to it. So I know that we have done some education about postpartum depression. We had done the Edinburgh postpartum depression scale together, and we'll do that again. The hospital will also monitor for that as well. They will help you with the breastfeeding. You and I are doing the parenting class, and the neonatal abstinence syndrome. I know you and I have spent a long time on that, just educating you on what to expect, what things can happen with the baby, and preparing you for some really good ways to comfort the baby and help to lower the stress of the baby.
I'm so glad for that, because you would think with all these different people I'm working with, because if you look at it, I'm working with quite a bit of people. No one really explained to me like you have, what can happen to the baby, after I have the baby.
So I wondered, how are you doing as far as where you're feeling in terms of like having everything you need for the baby and having like your hospital bag packed? And that's kind of where we're at. I mean, getting the bag ready, and
We're down to the final straw here. I have everything ready. We got to find out about we got to still get the breast pump. And I also wanted to see if after I have the baby, if me and you can discuss getting me a medical worker who can keep all my doctors like informed with what the other doctors do. You know what I mean? So everyone's knows what's going on with me.
so maybe like a case manager that can kind of help you juggle all the medical appointments and outpatient appointments, and would talk to each of them on your behalf too. We could certainly do.
I'm babysitting.
I hear a little one in the background. So you're
Yeah,
getting some practice in before the baby comes.
Yes, you could say that.
Well, Danielle, I really appreciate that you've taken the time today to do this and to go over this once again. And we'll plan on meeting again next Friday so that we can just go over everything else just to make sure we're all good.
Okay.
Do you have any questions or anything else?
I was just looking at my list. I think we answered them all. Oh, yeah. I actually have one more question. Actually, after I have the baby, are you still involved with me?
So you and I will keep working together on the parenting classes and also in outpatient.
Okay.
Yeah.
Well, I think that's it.
Now that Monica and Lisa and Danielle have done an amazing job of explaining what a plan of safe care is and how they help mothers and their babies, I'd like to spend a few moments going over some statistics that further explain why plans of safe care are so important. So as you can see from this slide, I'm going to quickly review what is happening on the national level surrounding NAS and child removal. Sorry, my slides aren't, there we go. As this slide points out, incidence rates of NAS and FASD are rising, as are costs associated with both. There's also been a concerning increase in the prevalence of alcohol and other drug use as a contributing factor for child removal. As you can see, research that was recently published in JAMA indicates that between 2010 and 2017, the national incidence of babies born with NAS increased 82%, and the number of mothers with an opioid-related diagnosis at delivery increased by 131%. However, it should be noted, and I'll discuss on a further slide, that rates of NAS and opioid-related diagnoses vary greatly by state. For example, Nebraska's NAS rate is around 1.3 per 1,000 births, and West Virginia's NAS rate is 53.5 per 1,000 births. And there's a national average of 6.8. So as you can see, there's a lot of variation. As many of you may be aware, it costs significantly more to treat a newborn with NAS than it does a baby without. As the graph shows, a hospital stay for a baby with NAS is nearly 8 times more than a baby without. Nationally, around 84% of all NAS treatment costs are charged to a Medicaid budget. There are, of course, very human reasons that we should want to decrease NAS diagnoses in the US, but we also cannot ignore that there are financial implications as well. While much attention has been placed, and rightfully so, on NAS and opioid use among pregnant women, we mustn't ignore the fact that one of the most commonly used drugs during pregnancy has been and continues to be alcohol. As you can see from this slide, around 14% of women report drinking during pregnancy, and 5% report binge drinking, which equates to 4 or more drinks within a 2-hour period. Like NAS, there are economic costs associated with FAS diagnosis, with the National Organization on Fetal Alcohol Syndrome estimating that FASD costs the US approximately $5.4 billion in direct and indirect costs. FASD has the potential to cause intellectual and developmental delays, which may impact long-term socioeconomic statuses of these children well into adulthood. So to me, this is a really important slide because, as we have learned, one of the biggest reasons for implementing a plan of safe care is to keep mother and baby together in the home. SAMHSA has reported that between 2000 and 2019, parental alcohol and drug use as a contributing factor for child removal has increased to 21%, with a plateau between 2018 and 2019. And I can only imagine what COVID has done to these numbers. If we look at similar data, we see that most reasons for child removal from a home have decreased, such as physical abuse, sexual abuse, and child behavioral problems, while parental alcohol and drug use, neglect, and incarceration are actually increasing. Additionally, children under the age of 5 represent over 50% of children entering foster care, with a significant portion of them under the age of 1. And I'm going to detail this more on the next few slides. So as you can see, SAMHSA has displayed the number of children who entered out-of-home care by age in the US in 2019. 60.3% are under the age of 5. It is well documented that child removal at any age, but especially before the age of 5, is associated with negative psychological and social implications. Of course, the safety and well-being of children must always be a top priority, but we must not ignore that the impacts on removal of children's they impact child's well-being, which is why a plan of safe care is so important and such a wonderful tool in trying to mitigate these negative outcomes. As I previously mentioned, NAS and FAS vary greatly among states. This graph depicts the variation of child removal by age, with alcohol and drug use as a contributing factor by state. As you can see, New York is doing better than a lot of other states, but there is still a lot of work that needs to be done. It could also be noted that states that tend to have higher opioid mortality rates also have higher rates of child removal. So quickly, I'd like to dive a little deeper into what's happening here in New York. While many regions are struggling with FAS and NAS, recent data from 2019 indicates that the Western region of New York has the highest incidence of NAS, with 5 out of the 10 counties there having the highest NAS rates in the state. In New York, the majority of medical costs associated with NAS were paid by Medicaid or a Medicaid managed care plan. As I previously mentioned, costs associated with NAS hospital stays are on average 8 times more than the cost of a baby born without. A lot of this has to do with the length of stay a baby with NAS requires in the hospital. Data from Crouse Health indicated that the average length of stay for a baby with NAS is 16.8 days compared to just 2 for a baby born without NAS. And lastly, as I previously indicated, the majority of medical care costs associated with a baby born with NAS are paid by Medicaid or a Medicaid managed care plan. This means that most mothers and babies that could benefit from a plan of safe care will be low income and underserved. Now, that isn't to say that only this population needs a plan of safe care. We know that substance use spans all socioeconomic statuses, but many of these mothers may not have the same access to the resources and interventions, which is why plans of safe care are so vital and important to changing these statistics and the lives that these numbers represent. Thank you so much for your time. I'd like to now go over to Dr. Ajabi, who is going to examine the dynamics of working with pregnant women with substance use disorders.
Hi, good morning. Good afternoon. My name is Talani Ajabi. I serve as the Chief of Psychiatry and Medical Director of Addiction Treatment Services at Crouse Health. I'm hoping this morning the objective of my part of the presentation is to talk about addiction in general a little bit, talk about some risk factors for addiction, and also specifically some risk factors specific to pregnant women. I'm also going to talk about how to approach pregnant women, especially in primary care and OBGYN settings, effects of specific commonly used substances in pregnancy also I will touch on, and also lastly, evidence-based treatment of those specific substances. So first, what is addiction? So most of us have probably seen this definition before. This is a definition come up by a consortium of organizations involved in addiction and pain treatment. It defines addiction as a primary chronic neurobiologic disease that has genetic, psychosocial, and environmental factors influencing its development and manifestation. So basically what that means is that addiction follows what we call the chronic disease model. A chronic disease model identifies the fact that there's some diseases or illnesses that are chronic, they're manageable, they're controllable, but they're not curable. So these are lifelong diseases that people go through remissions and relapses and for the entirety of their lifetime. Sometimes they're in remission for such a long time, and in different fields they get termed that as cured, but nobody's ever cured of those diseases. They're on and off. So addiction falls also the same model. Under certain circumstances, it could be stress related. People sometimes will relapse. So you will see that with diabetes, with hypertension, neurological conditions, like Parkinson's, multiple sclerosis, autoimmune diseases, you see the same model. It's no different from addiction. So this is very important to talk about in such a way that people understand that addiction is not just some kind of will problem or a moral failing of the individual who suffers from it. Is something that should be paid attention to as a disease that manifests in certain ways. So specifically, what are the risk factors for addiction? There's a ton of them, right? Genetic predisposition to addiction is about 50%. So the risk of addiction is already 50% genetic, which means some people, even the day they're born, they're already halfway through that risk of developing addiction. All they need is to be exposed to such substances somewhere along the way. And if you know how things work in life, especially during the early teenage years, getting exposed to psychoactive substances is not so unimaginable. Other things that can put someone at risk of addiction is how early in life they start using substances. So if somebody is exposed to substances at a time when the brain is going through critical development, and you can alter the chemistry of the brain in such a way that somebody can then become dependent. The brain is hijacked by the drug, and somebody becomes dependent on that substance to even function at all. Trauma has been studied heavily and found to be a major risk for addiction. People self-medicate, trying to emotionally mute themselves from the pain of past trauma and dealing with recurrences and relieving experiences, flashbacks, nightmares, stuff like that. So trauma and PTSD are major drivers for addiction. Some people suffer from mental illnesses, medical disorders that cannot self-medicate the symptoms. If people have depression, anxiety, PTSD, insomnia, all types of things that makes them use substances that can potentially give symptom relief. Also predisposition, genetic predisposition, family history can also predispose someone to addiction. Psychosocial factors, stress, burdens of issues or social issues, homelessness, unemployment, poor social network, um, um, you name it. Any kind of psychosocial factor can become an issue. COVID was a recent stressor that we all had. People were sheltered in place, they were unemployed, financial difficulties, lack of interpersonal relationships. All those things contributed to the worsening of addiction. And we've seen that in the number of addiction cases we're seeing and also overdose cases in our community here, in our community and beyond. So cultural practices, certain cultures find certain substances acceptable. The one that worries all of us now is how marijuana has been accepted and just, um, perceived to be without harm in a lot of quarters. So that needs to be watched. So next slide. So in terms of specifically about pregnancy, why are we so worried about it? Because if you think about the reproductive age of women, it's between the ages of 18 and 44. And every study that we've seen, every large size study shows that between the ages of 18 and 29, more specifically 18 and 25, is when you see at the most substance exposure when it comes to age groups. So the reproductive age is actually a high risk for substance exposure. So this is a time when most women will get pregnant, so which now translates to a high risk of exposure of the pregnancy and in effect the fetus to substances. So the National Survey of Drug Use and Health, as far back as 2012, shows these types of numbers. Even around that time, there's been other studies. Even since that time, there's been other studies, like a particular one by Dr. Chasnoff, Era Chasnoff, and her group. They looked at 40 states across the country. And what they figured is that even these numbers are much less than what the actual numbers are. Because this National Survey of Drug Use and Health utilized self-report, confidential self-report by women of drug use. Well, what that other study did was to use urine drug screens. So they had quite a good number of women who were recruited for the study, and they did UDS, and they found that the numbers were like 3 times what you're looking at here. So basically, what that means is that even till now, so there's some women do not report. Sometimes, first of all, some women do not even know they're pregnant in the first trimester of pregnancy, in the early stages of pregnancy. The second part is some who are aware they're pregnant will not report it because of the risk of worries about retribution. In some states, they can actually be legally prosecuted for exposing a baby to substances or maybe having the baby removed. So because of that, there's an underreporting of these numbers. But those are the kind of numbers that we have. If you look at those numbers, alcohol is about 550,000 kids were exposed to tobacco that year, more than to alcohol and more than 1 million to tobacco. The reason why that is so, across board, alcohol is the most used substance across board. But for this group of pregnant women, is tobacco, because I think there's more education about the high risk of alcohol use and fetal alcohol syndrome. And more women discontinue alcohol during pregnancy due to the perceived risk associated with that. But we don't have the same level of worry about tobacco. So it says about 60% of women actually stop drinking when they get pregnant. So that's why the numbers are skewed the other way. Can you go on? Like I said, most commonly used substance is tobacco, followed by alcohol, then marijuana and cocaine. If you look at the numbers as well, when it comes to stillbirth, you see that between 2 and 3 times greater risk of stillbirth compared to women who don't smoke. For various reasons we're going to talk about later. Marijuana use is 2.3 times greater, has a greater risk of stillbirth 2 to 3 times than people who don't use marijuana. Then other substances as well are on the same rate. Sudden infant death syndrome is also seen in mothers who drank or smoked even beyond the first trimester of pregnancy. The first trimester of pregnancy is the most significant period for people who are exposed to substances because you have most of the organ development of the baby happening during that time. So introduction of drugs and alcohol during that period can have very serious effects. Or SIDS cuts across all semesters of pregnancy, the risk of SIDS, and is actually seen to be like 12 times worse after the first trimester of pregnancy and into even after the delivery of the baby for mothers who continue to smoke after delivery of the baby. This slide just talks about it's a national survey of drug use and how that's the largest study of substance abuse in the country. I think that they survey about 65,000 people, and then so that study finds about 10% of women, for pregnant women, said they've had at least one alcoholic drink in 30 days. So these are current drinkers. Of those, 40% actually use multiple substances. So this is a situation that's serious enough. And like I said to you before, because these are just self-report confidential surveys, the actual numbers of when they use drug screen for other studies like 3 times this. So this is a highly prevalent problem. Go on. So what are the specific risk factors for these kinds of numbers in addiction? In pregnancy, extreme stress. So pregnancy on its own brings a lot of stress, physical stress, emotional stress, psychological stress for women. On the physical side, this is a high risk for, anemia, immune dysfunction, even the weight gain, problems of mobility, problems of functioning, all these things. Can you go back? Sorry, one sec.
I'm sorry, something just weird just happened to my, I'm sorry about that.
Thank you. So those are, there's a lot of physical changes going on in the body of a woman, and also emotional, psychological areas as well. Some women don't have the kind of family and social support that they need to go through pregnancy successfully. So it creates a lot of burden. Employment. So you have to show up at work and you're pregnant, and it's sometimes difficult to carry on with daily activities or even with domestic activities. There's also increased risk of trauma, domestic violence during the period of pregnancy. That's been proven by different studies. Mental health issues, depression, anxiety, poor sleep, and emotional response to trauma. There's just a lot. It could be a chaotic period. That's why pregnancy is actually considered a medical condition, because there's a lot of things. It follows that the medical model with the biological, psychological, and social models contributing to it. Poor nutrition, poor living conditions, social issues. So there's just a lot of things, environmental stress. There's a lot of things that contribute to the risk of addiction, because what tends to happen is during this kind of situations, pregnant women will sometimes if they already have an exposure to addiction, and even some new initiates can happen during pregnancy. They suddenly start using substances to self-medicate, to cope with stress, to regulate their mood, to sleep, to relieve anxiety. So it puts them at a lot of risk. But, so what do we do about this? So if you're a primary care provider or you've made exposed to a pregnant woman in an outpatient setting, or you're working OBGYN, we just encourage a lot that you should be screening for. Everybody should be screened for pregnancy, for addiction and pregnancy. Screening, brief intervention, and referral to treatment. How does that screening work? So it's recommended that you screen every patient for addiction. There are different screening tools out there. The 4Ps, NIDA, the CRAFTS screen, TWIG. There's so many of them. The 4Ps, I think, has to do with the pregnancy. You ask questions about use of alcohol and nicotine in pregnancy. You want to know about the parents of the person, of the pregnant woman. You want to know about the partner, and you want to know about their past. So if they've used in the past and all that. So from those screenings, based on how people score, you determine what kind of intervention they need. You determine the level of risk and what kind of intervention is necessary. It is recommended that women be screened in the first visit of prenatal care and also every trimester afterwards, because some people, may not be there when they start, but may be there along the way because of the stress. So patients who have mild risk, we just need to educate them about addiction and the risk of it. Or if you have moderate risk, basically that means that somebody who's had history of substance use in the past, substance treatment, but they're not actively using right now. So you can provide some brief intervention in the office, like that people who stop using during pregnancy or they use very low levels sporadically. You can do that brief intervention in the office setting. But if they're high risk basically means they can't really use it. Whether it's everyday or repetitive use, it's best to refer them to specialists for the care that they will need. What are the effects of the substance exposure on pregnancy? There are two ways. There's direct potential long-term effect on the baby, and there's also there's effects based on intoxication or withdrawal from the substance. So teratogenicity is more of the long-term effect on the baby. So when a baby is exposed to a substance or medical condition, it can alter their physical appearance or physical structures, their psychological functioning, and also their behavior if the mother is exposed. Or teratogen can affect the baby that way, but there's something called the critical timing and critical dosing that can contribute to that. So the fact that somebody uses substance doesn't mean the baby naturally develop that condition. So if the timing and the amount of substance exposure are both right, that is why you have a teratogenic effect on the baby. So the most important period that we worry about when it comes to that teratogenicity is the first trimester, the first 12 weeks of pregnancy. So introduction of substances, even nicotine, alcohol, stimulants, opioids in those times can affect babies in different ways. Another period that we worry about a lot is the last trimester as well, because whatever is used in the last trimester can affect the maturity of the baby. You can put a woman in preterm labor and preterm delivery of a baby. Then there comes all the problems of prematurity in the newborn, and also neonatal abstinence syndromes, depending on the substance. So the timing is important, and the amount of exposure is important. There was a study that looked at alcohol exposure, for instance, and showed that the risk of developing these teratogenic effects is 0.8 for people, for heavy drinkers, compared to binge drinkers that have about 4%. So the fact that you drink a lot very quickly even puts baby at risk compared to people who just drink heavily but spread it out. So there's a lot of factors involved in that. So the exposure can cause problems during any trimester of pregnancy, even though it's worse during the first trimester. Neurological development occurs throughout pregnancy. So a child that is exposed to any substances at any point, second trimester, third trimester, you can have problems with neurological problems when they're delivered. Alcohol and tobacco have the highest potential for causing teratogenic effects. Opioids are not known so much to cause teratogenic effects, even though they can cause problems of prematurity, premature delivery, growth rate deficiency, growth restrictions, small for gestational age babies, and all the things that come with that. Like I said earlier, the other way that the exposure to substances can affect a child is by the intoxication or withdrawal syndromes that we see. So what determines that is what substance, because specific substances have specific effects of intoxication if they're used so close to delivery, or withdrawal and also when they use so close to delivery, even for withdrawal as well. and depends on the substance or combination of substances, when was the last time the substance was used, and our metabolism of the drug. So we know that the metabolism of the baby is kind of slow, but they have a very immature liver and immature metabolism. So even the mother hasn't used for days before delivery, as long as it's already passed some on to the baby, it can still be in the system and not metabolized as fast as it will be metabolized in the mom. So basically, if there's any history to suggest or drug screen that suggests that a baby has been exposed to intrauterine, it's best that such a baby is monitored in the hospital for development of any kind of abstinence syndromes or withdrawal syndromes. Monitoring for about 3 to 4 days is recommended. If the baby is going to be discharged before then, we strongly encourage the mother or other support network to monitor the baby for any developmental symptoms. For opioids, what are the things that we commonly see? Placental insufficiency. So the biggest problem with somebody who's pregnant and using opioids during pregnancy is withdrawal symptoms. So withdrawal syndrome will cause a lot of what we call hemodynamic instability, blood pressure fluctuations, mostly hypertension, which affects perfusion of the placenta. When the placenta is not perfused well, there's lack of delivery of nutrients, including oxygen to the baby. That puts the baby under stress and put the pregnancy under risk of termination. So you can see miscarriages in the first trimester, preterm labor, preterm delivery in the third trimester, problems of prematurity in such a baby. Also, opioids can cause premature detachment of the placenta, known as the placental abruption. So such babies can be prematurely aborted. For the mother, it can cause preeclampsia, eclampsia. These are dangerous conditions that sometimes will kill the mother as well, not just the baby, they can kill the mother. So these are things that we worry about, and the risk of death or stillbirth. So these are things that can potentially happen with mothers who are using recreational opioids during pregnancy. What do we do about it? So the evidence-based treatment for such situation with opioid use disorder in pregnancy is to put the patient on what we call medication-assisted treatment. So medication-assisted treatment includes the use of opioid agonists, opioid medications, and also behavioral treatments. So for the medication part, the gold standard is to use methadone for such treatments. The other option or alternative is to use buprenorphine. So basically, the goal of these two medications in treating the mother with opioid addiction is to help to make sure to prevent withdrawal syndrome, which I said is the most lethal threat to the baby. So they prevent withdrawal symptoms and they help the mother with cravings. And also they've been studied and found to be safe for the baby. They do not increase the risk of addiction in a child. Yes, they can cause neonatal abstinence syndrome, but is much less risk compared to mothers who are using heroin or other illicit opioids on the streets. So a study called the MOTHER Study, Maternal Opioid Treatment Human Experimental Research, compared methadone and buprenorphine. I found that they're both equally effective. So, well, but there's a caveat to it. So the moderate doses of methadone compared to the highest doses of buprenorphine are equally effective. Patients who are going to need very high dose of methadone will probably not do well on buprenorphine. So patient selection is a very important thing. So sometimes, patients are already in the treatment, they're taking Suboxone. We typically switch them to the buprenorphine only preparation, which is Subutex, and keep them on that. Some patients can decide they want to switch to methadone, or maybe they're already on methadone and we keep them there. So these are very safe treatments in pregnancy for opioid addiction, and they have very good outcomes with the babies. Now, neonatal abstinence syndrome, yes, there is. Comparing methadone to buprenorphine for NAS, buprenorphine is better than methadone because the babies for buprenorphine will require, first of all, they will score less in terms of severity of symptoms. They will require less opioid replacement with maybe morphine or methadone. They will require less morphine while they're in the hospital. And they will also be in the hospital for a shorter period of time. I think methadone babies will be typically on the average will be in the hospital for 17 days. Buprenorphine babies will be there for 9 days on the average. So those are the advantages. Otherwise, they're comparable. The other medication-assisted treatment talk about is also Narcan, naloxone, but which is a life-saving opioid reversal agent, opioid overdose reversal agent. So sometimes, unfortunately, sometimes you will see a pregnant mother who overdoses in pregnancy. It is recommended that you don't use Narcan you only use Narcan as a last resort because of the risk that is associated with Narcan as well. So there's a risk of termination of pregnancy because of the sudden withdrawal syndrome the mother is put into, causes a risk of spontaneous abortion and intrauterine death. So if not absolutely needed, you should avoid Narcan. So, and also there's a risk of a heart failure, so-called a broken heart syndrome from using Narcan in patients who are already using long-term opioids. The third type of treatment is medically supervised withdrawal. This is basically it is strongly discouraged to use this as a form of treatment. You only use this in mothers who decide they do not, under any circumstances, want to be maintained on opioid agonists. So what we do is that we still treat them with opioids with a goal of tapering them off completely. Typically, that will happen within 28 days. Is medically supervised withdrawal. It may take longer if they're willing to, but their goal is to just be put on the opioids to be tapered off very quickly because they don't want to maintain themselves on opioids. Sometimes because of lack of education about the benefits, and they say, well, they don't want to expose the baby to the opioids for too long. So if you don't have a choice because it's not either because the mother is declining or it's not available, I would always recommend that we do MAT, medication-assisted treatment, and not this medically supervised withdrawal. What are the risk of relapse? 50 to 90% will relapse. And you know what happens when people relapse after abstinence? Sometimes they overdose. Sometimes they go back to their old life and end up with, a lot of complications of the pregnancy itself, loss of pregnancy, infections during pregnancy, all kinds of things will happen during that period. So it's strongly discouraged. And if it's to be done, it's best done on the inpatient service, on the inpatient addiction service. The other treatments are counseling and behavioral therapies. The different ones have been looked at: outpatient, individual and drug counseling services, inpatient, outpatient rehab, behavioral interventions like motivational interviewing, CBT, contingency management. Motivational interviewing and contingency management have been strongly encouraged in pregnant women for different substances, and also 12-step facilitation, AA, NA, anyone the patient prefers. When it comes to neonatal abstinence syndrome specifically, about 60 to 80% of babies who are exposed to heroin in pregnancy develop neonatal abstinence syndrome. Symptoms start within 1 to 3 days after birth and will last up to 5 days. We probably know about neonatal abstinence babies. They're very uncontrollable, unconsolable, hyperactive, crying spells, a lot of central nervous system symptoms, they breathing difficulties. Sometimes they go through apneic episodes. They're very uncomfortable. It's usually managed in the ICU because of how symptomatic the patient can be and the severity and the risk associated with this condition. So, but the treatment for it is typically to put them on an opioid agonist and slowly taper them off it. Depending on the substance they use, how long they've been exposed to the substance, depending on the substance they're exposed to and how long they've been exposed to the opioid is what determines how long they're going to be on that taper off, whether it's morphine or methadone they use. So these are the scoring tools for assessment of neonatal abstinence syndrome. Finnegan neonatal abstinence scoring tool is the most commonly used one, and it's known one called the Mother's NAS scale. So for both scales, they just score the severity of symptoms, and based on the numbers, they determine if the baby will need to be treated with morphine and how much they can get during that period of time, and when to start weaning them off and how long to wean them off. So these are guiding tools for treatment of neonatal abstinence syndrome. For opioid NES treatment, like I said, we need pharmacological intervention. Not everybody that has NES will require medication management. So sometimes some children will not score so high that they will need it. So about 50 to 70% will need med management. Like I said, if the symptoms are getting worse and worse, there may be treatment may be administered with morphine or methadone. There can be other adjuncts used in babies. In the past, we used phenobarbital or clonidine. We rarely ever see those things again. Requirement is that the baby should be nursed in a quiet environment, minimizing stimulation, whether sound or light stimulation. Typically, it should resolve very quickly as the opioid is tapered off. But for some cases, depending on how much the substance, how long they've been exposed, it could take 2 or more weeks for them to be completely tapered. What are the benefits in the mother? Prevention of relapse when they're maintained on either methadone or buprenorphine, reduction in substance use, reduced risk of infection because some people use intravenously, IV drug users. So if they can abstain from using, there's a lower risk of those vertical transmissions to the baby of hepatitis or HIV, and also increased engagement in prenatal care or other healthcare system needs that they have. For the baby, reduction in the exposure to the illicit substances, including opioids, for instance, prevents the baby from repeated withdrawal syndrome. So the reason why most people who are using opioids on the street will lose their pregnancies because of repeated withdrawal syndrome. So that's the number one risk that they face. Spontaneous abortion, preterm labor, small for gestational age babies, problems of prematurity. Those are complications that can also happen as well. And also overall morbidity and mortality is high for some babies whose mothers were not on MET. When you talking specifically about alcohol, it's been emphasized by the American Academy of Pediatrics that there's no safe amount of alcohol to consume during pregnancy. So that some people try to minimize this issue and try to say that, if you don't drink more than a certain amount as a woman, will be safe, the baby will be fine, but that's not been proven to be true. There's so many numbers all over the place. And what has been seen is that people who actually advocate that kind of idea is because they're worried about the fate of the woman. Like, okay, if we say it's unsafe, then there might be persecution of women who drink at all in pregnancy. So they come up with all this kind of ideas. But in general, the American Academy of Pediatrics says there is no safe amount of alcohol to drink in pregnancy. So the recommendation is you completely abstain from it. And other illicit substances, by the way. Like I said before, about 60% of women, according to the National Survey of Drug Use and Health, will stop drinking alcohol during pregnancy. People who have sedative use disorder, sedatives like benzodiazepine, barbiturates, will sometimes use combined substances, including alcohol. So if they have a desire to use, a tendency to use CNS depressants, they will use a combination of them. Treatment of acute withdrawal from alcohol and sedatives in pregnancy will need to be done in a safe place, in an inpatient service, and it needs to be medically supervised. Even for non-pregnant subjects, it could be a potentially dangerous withdrawal syndrome because of the risk of seizures, coma, and death. And, for alcohol, even delirium tremens. So imagine when you now have to deal with pregnancy on top of that, that takes the risk to another level. So it's best done on an inpatient service. Also, like I said before, motivational interviewing has been proven to actually reduce prenatal alcohol use. So that could be an approach to psychosocial treatment during pregnancy. So what are the bigger complications? What are the complications of alcohol use? Like we talked about with other substances, miscarriage, stillbirth and infant mortality, preterm delivery, small for gestational age babies, low birth weight, problems of prematurity in the baby. All those things are also relevant to alcohol. Then the fetal alcohol spectrum disorders. So these are babies that have been exposed to alcohol during pregnancy. Unfortunately, unless the babies have severe fetal alcohol syndrome, they're often not picked on. So those cases of mild to moderate, because they don't have all these physical changes, appearance changes, sometimes we don't pick on it. Maybe sometimes later in life, that when they're having significant difficulties in intellectual functioning, on school performance, that they now, we get IEPs and diagnose them. Even sometimes we can diagnose them with just the psychiatric conditions, ADHD, um, dysregulated mood disorder. We give them all kinds of diagnoses, and nobody ever makes a connection to fetal alcohol syndrome again. So that tends to be the case. So yeah, babies that have, physical symptoms like growth retardation, problems that you see, what they typically will have is the height, the small height for the age, weight, head circumference, the brain size, brain growth, all those things are diminished. They have facial deformities, very narrow eyes, flattened nasal bridge, thin lip. If when you see those features, you can recognize them. And they have problems with intellectual functioning. They have other neurological problems, psychiatric problems. They can have problems with heart defects, problems with vision, with hearing. There's just a lot of things that come with the territory. And because there's been a lot of effort to educate mothers and pregnant women about this, that's when you see that large number of people discontinue alcohol during pregnancy. Unfortunately, they can switch to other substances, which they perceive to be less dangerous, like cannabis. So that's one thing. Yeah, so these are some of the things I was explaining before. Up to 1 in 20 US school children may have fetal alcohol syndrome disorders. And, I'm sure most of them are not diagnosed yet, but you see the features. The growth restriction issues I talked about, the facial appearance issues I've talked about, the problem with the damage to the brain, neuropsychiatric issues, learning disabilities, intellectual function disabilities, behavioral problems. They tend to come with ADHD, oppositional defiance, dysregulated mood disorders. So all kinds of things that we see. And they're lifelong issues as well. I put them at the risk of substance use. So of all the substances, alcohol is the number one substance that put the children at the risk of addiction later in life. So that's number one. And it's also the number one cause of intellectual disability in children. Number three cause of birth defects of all substances. So alcohol is a very dangerous drug in pregnancy. So there's no way to even get around that. Go ahead. When it comes to tobacco, there's almost the same thing. This is probably the number one use in pregnancy because of the people trying to curtail their alcohol use, but it's equally dangerous as well. Use of nicotine causes placental problems, whether it's early detachment of placenta or placental hypoperfusion, increased risk of ectopic pregnancy, miscarriage, preterm delivery, small for gestational age, all those things that we talked about. And also the increased SIDS, increased risk of sudden infant death syndrome. So when a mother smokes during pregnancy or expose the baby to secondhand smoke after delivery, there's a 3 times more higher risk of sudden infant death syndrome with the baby. When it comes to cannabis, 2 to 5% of pregnant women use cannabis. Regular cannabis users, about 30 to 64%, as scary as that sounds, continue to use while pregnant because they believe it's safe. So for those who use prior to pregnancy, almost half of them on the average continue to use because they think it's safe, except that it's not. The same things that we talked about for other substances also applies for cannabis. And it affects the brain, it affects cognitive functioning, neurological functioning of the brain. So the babies are born. The first thing that they notice is the difficulties with attention, visual spatial functioning. They have difficulties with alertness. So we have a baby that's just can't like open their eyes and just be present in the moment. So even though some studies say by the age of 3, those things go away, but some other studies say they persist for a long time and they put them at the risk of problems with attention and all these other neurological, other cognitive functioning later in life, behavioral problems. So cannabis is not that safe in pregnancy to any amount. The recommendation is to avoid using cannabis in pregnancy and also after delivery. All these substances cross into the breast milk. it should be avoided in nursing mothers as well. Cocaine, methamphetamine, also the same things. There's some unique things to this one. It has to do with hypertension, gestational hypertension, eclampsia, preeclampsia. Some of these things put both the mother and the baby's life in danger. Intrauterine death, preterm labor, small for gestational age, all those things are there. Developmental and behavioral problems, problems later in life with motor and cognitive development. So you see them with both cocaine and methamphetamine. So this use actually, cocaine, methamphetamine put both the mother and the baby's life in danger because of the placental abruption and also other forms of uterine bleeding in pregnancy. Sedatives. So when you talk about sedatives, talking about like things like benzodiazepines, barbiturates, alcohol itself is a sedative. Some sleeping pills, we call them the Z drugs, the Ambien and Nesta. What's the other one? Sonata. So these are all disease sleeping drugs, but they're classified as category D drugs, which means they've been studied in humans and found to cause harm to the baby, to pregnancy. But if in very rare situations, if you determine that the benefit outweighs the risk in using it, then you can go ahead. It's very limited, but but category X also has some benzodiazepines in it, but those ones have been determined that you, under no circumstances should you use them in humans. So most benzos are category D, which is not great. So nobody should be using Xanax or Valium. These are actually, benzodiazepines also have a risk of causing birth defects in babies. So they literally just declared, do not touch them. Now, in very rare limited circumstances, if you're going to be a life-saving thing, yes, you can consider using it. Or if it's a category X, it should not be used at all. Benzodiazepine used in pregnancy doubles the risk of C-sections as well. Go on. So lastly, specific treatment during pregnancy. So unfortunately, there's not been any evidence-based medication management of specific substances. It's considered most medications to be controlled during pregnancies. Unless it's absolutely indicated, we try to avoid them because they have tendency to cross into, cross the placenta barriers and cause side effects and cause issues with the baby. So if medications can be avoided, we'll go there first. Or if it's something that saves lives, if you need something for withdrawal management for the mother, absolutely. That's what MAT and all those treatments are for. But what's been proven, evidence-based treatment for these substances is the behavioral treatment and psychosocial treatment. So for alcohol, that will be motivational interviewing. That's been proven, like I said before, for prenatal alcohol use reduction. For tobacco, what's worked best has been contingency management with reward, financial incentives, alcohol for tobacco. CBT, MI-based intervention, I've seen moderate success. Unfortunately, NRT has limited efficacy in tobacco, for tobacco cessation. For cannabis, is SBIRT, because screening, brief intervention, and possible referral to treatment, because sometimes you see somebody who's using very heavily, they might need to be referred to formal treatment. For screening and brief intervention have been proven to be very helpful in most cases. Other ones, MI-CBT, contingency management also work, but screening and brief intervention has been the best. Cocaine, contingency management with incentives have worked, followed by motivational interviewing and CBT. This treatment with oral micronized by progesterone for postpartum cocaine use. So what tends to happen is after delivery of children, there's some hormonal changes that go on in the mother. One of the major ones is the drop in progesterone level. And that's actually the major cause of postpartum depression. So if you can replace progesterone, hopefully you can control a lot of the postpartum depression symptoms. And since depression can be one of the motivators for cocaine use, then the cocaine use, the need to use cocaine will get lower. So that's what this treatment is. Still a new treatment still being looked at. That's what the goal of that treatment is, to control the hormonal changes after delivery, which then reduce the need, the craving for cocaine. And for methamphetamine, it's reinforcement-based therapy is what's recommended. So I think that's the last slide. Yes, thank you.
Thank you so much, Dr. Ajabi. We do have a question that was submitted to me in the chat. Monica, I think this might be for you. It said, would the plan of safe cares that you've shown meet OASIS requirements?
So on the OASIS website, you can find the local service bulletin that in essence does say that certified OASIS providers have a responsibility in developing the plans of safe care. They don't give specifics in terms of what template to use. So I'm sure any of the templates that were shared during today's presentation would be fine. Did that answer the question, or? Not sure who it came from. Feel free to.
Came from a Laura Miller. She says yes.
Okay.
If there's any other questions, you can either type it in the chat or you can just unmute yourself and ask. Okay, if not, then we'll wrap things up. I just wanted to let everyone know that a survey is going to be disseminated for you to evaluate the workshop. If you could please fill that out. That's also how we're going to be sending out KSAC and CME credits. So please take a moment. If you have trouble accessing that survey for any reason, please just send me an email. You can see it up on the screen here, and I'll be happy to send you the link again. So if there's no more questions, and yes, I will be sending out a resource packet that has the slides, a template of a plan of safe care, and some infographics that you can use to share with providers or patients that you're working with. Thank you all so much. Have a great rest of your day.
Thank you.
Thank you.